everyone. Welcome to Rehabilitation Science at YouTube channel. We are here with a very interesting topic, Shoulder Simplified clinical trials. And we have with us Dr. Nidheesh. He will be talking about this topic. Dr. Nidheesh, we would like to have your consent for making your lecture live on YouTube, sir.
Yes, of course. Please go ahead. Yeah.
Thank you so much, sir. Thank you. And moderator today, we have Dr. Harpreet Singh. He'll formally introduce the faculty today and start the session. Dr. Harpreet, you can start the session now, sir.
A very good evening. Today on Rehabilitation Science Group, we have Dr. Nidheesh with us. He is Master's in Orthopedic Physical Therapy and has a second Master's in Advancing Physiotherapy Practice. He has his certification in orthopedics and manual therapy and has also worked with the National Sports Medicine Center for about 3 years. Currently, he is working in the musculoskeletal unit, managing musculoskeletal pain patients. We welcome you, Dr. Nidheesh, and to the Rehabilitation Science channel. And you may please continue with the session.
Yes, sir. Sure. Thank you, sir. Today, we're going to talk about shoulder simplified clinical triage. Firstly, I want to welcome you all, those who are watching the presentation now. And just to state that I'm no shoulder expert. I'm just a budding therapist, but the presentation is purely from the observation, from my clinical experience and from the studies that I read, thanks to all those experts in shoulders. And also for a special thanks to somebody who has inspired me. You'll see that in the last slide. And also a special thanks to my mentor from my workplace. Let's not waste time and we'll quickly get into the presentation. So first thing first, when we work in a musculoskeletal unit, the thing is lately we're seeing not just being referred by orthopedics or doctors, but also we have some first contact patients as well. Because very important, when we see first contact patients, if they haven't seen anybody else before, it's also good to rule out all the red flags. Red flags are something that shows that we can't deal with these patients and they have to be referred to the doctors. See the referral patterns, when we refer to doctors, when we talk to doctors, when we discuss about patients to them, this actually creates a good rapport between physio and the doctor. This is not just clinically, but also it will favor us in many ways. This is something that I used to follow when I was in India. I often used to discuss various problems with doctors and I would ask them, is it okay if I suggest something? This is what I've seen. And doctors have always respected, because when they find out that we are knowledgeable and when they know that this is what we know and this is what we can do as physios, they always respect us more. So let's look into the red flags. So all the pain that is related to heart or lung or gallbladder or spleen generally will be referred into your left shoulder. So 69% of myocardial infarct patients experienced acute shoulder pain on their left shoulders, which is very, very important. The thing is, if you see that there could be no mechanical cause, and after ruling out, if they still have pain and it's suddenly developed and is referring in shoulder pain, and there are other symptoms that you can look for also, like pain in the left side jaw and left shoulder and increased blood pressure. So things like these complaints can actually always give us a picture that this could be something more than a shoulder problem, but it could be also something like a myocardial infarction or something like that. And ruptured spleen also can give us the pain, because considering the position of the spleen, a ruptured spleen also can give us a referred pain. So the same thing if you have in the right shoulder, if a right shoulder pain but with no musculoskeletal cause, that could be because of liver diseases, the position of the liver obviously, and any peptic ulcers and pancreatic related problems. So how do you actually differentiate red flags with the musculoskeletal problems? Because you should always look at them in a context. For example, like pancreatic related problems, patients might complain that they're having a heavy right shoulder pain after they eat a fatty meal, a heavy meal. So this kind of indicates that, because mechanical, it would be like when the patients complain that I have pain or overhead activities, when I do at certain positions, certain moments. Similarly, if a patient has pain right after he has a heavy fatty meal, that kind of indicates that it could be something related to pancreas. and gallbladder cholecystitis. So the pain in the right shoulder, gallbladder and cholecystitis. But if you see that the infections generally are associated with fever, vomitings. And looking down into the next point is where the Pancoast tumors, which is bilateral shoulder pain. So bilateral shoulder pain can also be, inflammatory in nature, but also if there's any primary lung cancer, considering the position of how close the lungs are to our shoulder, they generally give a bilateral shoulder pain. And 10% of metastasis generally affects humerus because breast is closer to humerus, lungs are closer to humerus, and also the worsening history. The thing is with musculoskeletal pain, and how can we differentiate between the red flags and musculoskeletal pain is like I said, look into the context. So we should also there are other red flags that are associated with metastasis and cancer related problems like sudden weight loss and patients' complaints of night sweats and loss of appetite and feeling feverish, fatigue. So you also need to look into all of the contextual problems. Then you can kind of, while you're ruling out things, you need to look into this context so that we will not ignore red flags, because red flags are something that are to be taken very seriously. Considering the way the practice is changing in India, we are actually becoming more independent day by day. We are assessing patients firsthand. So we need to keep these things in mind. And the last thing is mechanical in nature, generally fractures. It's quite surprising because we have an assumed picture of fractures generally cause a lot of swelling and severe pain. They won't be able to move hands. But I've come across 2 patients. They literally didn't had any symptoms, like very bad, very worse symptoms. They only had a history of mechanism of fall. But later on, after 1 month, like their condition has become very worsened and they had to go in for an X-ray. Then they found out that they had some fractures. So it's always good to palpate and see if there's any bony tenderness, and always look for the mechanism of injury. So that will kind of give you, a clear picture of, and also we can be sure of that we are not avoiding any, mistakes. We're not making any mistakes, and we are correctly identifying the problem, and we are referring the patients when it is needed. Okay, moving on to the next slides. So my clinics, I don't have a lot of time. So what I do is I divide my shoulders. I simplify my shoulder problems. So how do I simplify my shoulder problems? I name the shoulders as below. I name them as stiff shoulders. Generally, when I say stiff shoulders, the very word stiffness indicates what we are talking about. It could be frozen shoulder, ACJ, OA, and then our weak shoulders. Weak shoulders include weaknesses, rotator cuff tendonitis, bursitis, full thickness tears, muscle injuries, and wobbly shoulders are something, the unstable shoulders. Again, unstable shoulders, it can be, hypermobility. We can always do a Baton scale to find out the hypermobility, and also glenohumeral instability. And generally, they're associated with labral tears and full thickness tears again. And necky shoulders. Necky shoulders is something, if the pain is generally referred from the neck, at neck level, like for example, radiculopathies. And then nervy shoulders, nerve injuries at neck and shoulder levels again. So we can, generally what I do is I look in for myotomes and dermatomes, and I'll also look in for muscle wasting. And then you have not a shoulder at all, all the systemic problems. You have autoimmune disorders and polymyalgia rheumatica. The thing is, polymyalgia rheumatica generally doesn't, affect so many joints, whereas RA, you have RA factor and other symptoms. So once it is not a musculoskeletal problem, then I look into not a shoulder problem. And if needed, what I do is generally in RA problems, patients would say that they're experiencing pain in the middle of the night at around 2 to 4 o'clock in the morning. Generally is what they say, pain wakes me up in sleep. And then also they have problems that they say after I get up in the morning, I have stiffness. And stiffness that lasts more than half hour, close to 1 hour, 1.5 hours, and as we keep moving, it subsides. Generally, periarthritis shoulder, osteoarthritis shoulder, also we have the same problem. But generally, those patients would say that the stiffness would resume, their movements would resume back to normal within less than 30 minutes. But there is no textbook defined thing as such, but can vary from patient to patient. But this is how I simplify my shoulders as stiff shoulders, weak shoulders, wobbly shoulders, necky shoulders, nervy shoulders, and not a shoulder pain at all. And looking into subjective examination. So subjective examination, I would always ask them, just look into them and see if it has come from cervical pain. So I'll always look into, does moving your neck change any of your symptoms? And just to look into instability or weakness, I would always ask them, because patients would generally say that when there's a weakness or instability, they would generally say that I feel like my arm is really loose. I don't feel like my arm is, my shoulder, my arm is not connected to my body. I feel like it is dead. And few patients would say that if I think that if I do this movement, it is going to break, it is going to snap, it might come out. And then again, you have frozen shoulders or PA shoulder, where there is a global pain all over shoulder. They can't point out to certain structure, but they say they have shoulder pain overall, and with loss of range in movement and stiffness. And then SAPS. SAPS is something that we will discuss a bit more in detail in the later slides. It's subacromial pain syndrome. There'll be a sensation of weakness and heaviness of pain in overhead activities from 60 degrees to 120 degrees subduction. I'll tell them how I'm going to examine and how I'm going to differentiate the patients objectively. Then there is mechanism of injury. Is there always, you'll always find out, is there anything that could have caused the problem? Certain people will say, I lifted certain weight, I picked up weight from overhead, I fell down like this, and I was doing certain movements. Like, for example, a patient said that they were throwing a ball at a dog, at their very own dog. They kept throwing it repetitively. So you should always look in for mechanism of injury, because it will kind of gives you a clear picture of what structure could be causing this pain, or based on the mechanism, you might be also knowing that, okay, this might be leading to this. So other symptoms such as weakness, numbness, etc., can help you in planning the objective examination. So this is not there in the objective examination slide here, but how would I generally plan my objective examination is, it's always good to do this. There's a short form that I always have. It's MSC. MSC is must, should, and could. Must are the ones, the objective examination that you need to do. You cannot not do it, but you always have to do. And then there is should. Should is just to rule in things, and then it's could. Could is some things that you can always do if you prefer, you want to do it just to have more information. But must is very important always. And then there is diagnostic treatment. Diagnostic treatment is nothing but, so a lot of us would always want to look in to give a diagnosis to patients. Of course, the patients would want a diagnosis, but if we are very focused on giving a diagnosis always, then we would end up treating, the structures always, like, we are very structural in nature. But then on the other hand, I am somebody who would follow a problem-based examination and treatment. I would always like to treat the patients with their problems. I'll give you in detail of how I do and what I do. So for example, diagnostic, it's always aimed at identifying structures. Special tests, we have so many special tests. We have NIS, Hawkins, MTCAN. I'm not undermining the effectiveness of these tests, because we focus on learning a lot of special tests. We study a lot of good books to learn special tests. But what is literature telling us about special tests? So if we look at literature says that these tests are really sensitive. That means it can hurt people with problem and without problem as well. For example, you do certain tests and you push certain structures, then it might as well hurt the normal people also. Normal people also can complain pain. The problem is, most of the special tests, for us to be positive, the patient has to complain pain. This is how we learned in our graduation. We say that, okay, the test is positive because I put the patient in a certain position and I tried this moment and that moment, then the patient has complained of pain. So pain, we're taking pain as one of the tests to be positive. So as a sign for the test to be positive. So pain can be in people with problems and without problems, considering the way that tests are designed. And it is unrealistic that the tests will apply pressure on isolated structures. For example, we are doing a certain test and we assume that that test can only put pressure on certain structure, which is really untrue, because we have some really good studies. I would like these studies, I've given the references at the bottom of the page. So if you can look into this, you can gain more information on the sensitivity of these tests. So for example, if you want to look into specificity and sensitivity, what is sensitivity? Sensitivity can cause pain. Specificity is nothing but if you do the test 100 times, it will give the same result in different patients. So the specificity is what we need to look into. It's not always sensitivity. So if you want to look at each special test on their specificity and sensitivity, then we have some really good YouTube channels. Like for example, physio tutors or something, they're doing a great job. You can check out the video channel to look into how specific and how sensitive the tests are. And how will I examine patients? Since I don't have a lot of time, I have a few methods that I follow. And these few methods, the last two methods that I used in the problem identification part generally is something that I've learned by reading literature, especially literature by Dr. Chris Littlewood. So this is how Dr. Littlewood has even simplified his testing. So the first one is A and B rule. A and B rule is above and below rule. This is the ground rule that all clinicians should know. If I'm looking into shoulder, I would always like to look into the neck, which is the joint above, and I would always like to look into a joint below. It could be elbow or wrist if I want, because carpal tunnel syndrome can also give a global pain. It's not necessary that the pain is always radiating down from above to below, but it can also be from peripheries towards central. So for example, so what I do is I do an A and B. I would check the neck and I'll ask them to move, do certain neck movements and see, can you change certain neck positions and see if that is affecting, that if it's reducing the pain or that if it's aggravating the pain. That kind of indicates that something is coming from neck. And then I have rule out lateral rotation greater than 45 degrees, which kind of indicates that there's stiffness, something to do with restricted movements and stiffness. Generally, what I would look at is I would generally look at PA shoulder or anything to do with shoulder joint, OA shoulder, something like that. Then I have pain with restricted testing, abduction, lateral rotation. Pain with restricted testing, generally what I would do is when I see this, generally at 60 to 120 degrees, when I apply some resistance, and then when there's weakness with pain and resistance, pain with resistance, then I would classify them as, okay, this could fall under bursitis, tendonitis, and shoulder problems. So this is how I actually differentiate quickly. After differentiating quickly, and if I want to look into it, then I would identify the problems, and that's how I progress with my management with the patients. Then there are few tests which I would always do to identify certain problems. For example, what we are doing in clinical world these days is we are not just doing one special test to rule out, to rule in problems, but what we are doing is we are doing a cluster of tests. So cluster of tests, for example, neck, we have something called as venous cluster, what we would do. And then, for example, for shoulder, there's a very, very good cluster testing to identify full thickness tear. It has 91% specificity. That means that test is really, really effective to identify. If these tests come true, then drop arm test, painful arc, resistant for spinatus, then that clearly indicates that there is a full thickness tear. And to look into instability, the tests that are given below are a very, very good test, like sulcus test, relocation test, Niachi test that I would always do. And tests that I can blindly believe in is then again, nerve integrity and neurodynamic testing is something that I would always do. And I would like to look into nerve integrity first than being hot-headed and doing a neurodynamic testing, because if there's already a nerve is getting impinged somewhere and there's already, it's already short on oxygen, then you do stretch and nerve by doing a lot of neurodynamic testing that could actually cause potential harm to the nerve, more potential harm to the nerve. So I'd always look into context, like ask them if there's any change of sensation, if they're experiencing pain, pins and needles and numbness. And I would look into nerve integrity by looking into dermatomes and myotomes and see if there is, then I would get down to neurodynamic testing and see if there is, tension tests. Then clearly it's something that we cannot ignore or overlook is these subjective complaints. Patient telling that telling that I have lack of sensation, I lost sensation in these parts, like multiple dermatomes, or when patient tells you that he feels like it's a dead arm, patient's complaining of numbness and throbbing arm pain and swelling of hand, weakness, instability, cold intolerance, and then heaviness in shoulders and motor skills impairment, headaches. These are something that we cannot really ignore. And you always have tests, vascular tests are very, very important. Again, you have Roos, Adson's, right tests. And must test that I would always do is the tests for neural testing is very, very important. Also, it's good to look into, the thing is the world is changing quickly. Now with looking into pandemics like this, most of us, we would have at least tried a bit of virtual physiotherapy, because I have been doing virtual physiotherapy from last 153 days. I haven't seen a patient in person, but I'm actually seeing them all over the computer. And trust me, I have discharged so many patients with really great results. This actually has given a chance for the patients also to take responsibility over them and to show more interest in exercising than manual therapy. But at the same time, there are high chances, because I'm not objectively examining my patients. So what I do is I would always look into all the possible ways to test my patients. First thing what I would do is I will never ever would want to ignore any neural problems. So I'd always look into neural problems. I always try to test their motor functions by checking their grip, or by asking them to do certain movements and ask them to do resisted movements. So develop your very own ideology on how you can actually effectively assess patients on virtual, because in the times to come, if you want to go global, and if you want to see patients from all over the world, you need to have skills virtually, because that's how the world is changing. And I would like to discuss about the next thing is we're going to talk about research and the controversies that are around shoulder. So if you look into impingement, so the very word impingement kind of indicates that something is coming on, pressing onto something, or some soft tissue structure is getting crushed between two structures. Like, for example, there's muscle right here. When you lift your shoulder, the muscle is getting going under the bone, and it's getting impinged there, and that's causing pain. So this is something that the clinical world today is fighting with the advanced research, because impingement is quite normal. When you bend your knee, there's the same thing that's happening. A lot of soft tissue structures are getting compressed in the hinge joint. So that is the same thing. But we are making impingement as a term, which makes it sound like a disability, because I had one of my dental friends who is now practicing as a surgeon, dental surgeon, and he stopped playing his volleyball. Back then in my undergrad, I didn't really have a lot of knowledge to explain that to my patient. I regret it now, but still the thing is, he stopped playing volleyball. So I asked him, what is the problem? He said, I went to your department. So, and also the doctors explained to me that impingement is that when I lift my hand up to do the volleyball serving, I'm kind of impinging my muscle into the bone. The bone is coming and pinching onto the muscle, so I'm having pain. So that person completely stopped playing volleyball. That means it could be really something that he loves, but he has stopped. So we should be really, really careful. And the clinical world now categorized everything like impingement tendinopathy, subacromial pain, and the bursitis, and non-traumatic shoulder pain, unilateral, everything together as SAPS. SAPS is nothing but subacromial pain syndrome. So we should be careful on how we are explaining our patients about what impingement is, because if a bone is coming on, impinging on muscle, if this is the understanding of a patient, and if he comes to you as a physio, so he will definitely ask you, what are you going to do if my bone is coming on impinging on my shoulder? How are we going to change it? It is something for the surgeon to do. He has to either shave the bone, create the space, and that's how the patients will feel. So you need to explain the patients on what really is happening there, not by using terms like impingement, because that's not really the right way to explain problems. Then you have scapular dyskinesia. This is something that I always get into a debate with when I do webinars. This is one question that patients will, our clinicians will always ask me. So is scapular dyskinesia, is it a result of a pathology, or is it a pathology? Because studies says that this seems to be present in both painful and non-painful shoulders. If scapular dyskinesia is a problem for an impingement, then how is it not a problem for those in non-painful shoulders? And when in your very own body, you don't have pain, but one shoulder blade is different from the other. And when the shoulder blades can vary and the positioning can vary and the size and shape can vary in different people and genders, how can you actually say that this is a pathology? that this could be a possible cause for a certain condition. We don't know that yet. We don't know that yet. So the world of the world of science is really not clear about whether this is a result of a pathology, or if this is a pathology at all, if this is just normal. But from what I see is there's nothing called as abnormal scapula and normal scapula, because you can only call something abnormal if you know what is the normal. So there seems to be no normal, so you can't call something abnormal. Then something that we have been fighting, exercise standalone versus all other interventions, not just in rotator cuff tendinopathy, but in subacromial pain syndrome. I have presented with a very good paper that has come out recently, which I'm yet to read fully. I'm only halfway through because very recently that I've come across to the paper. But the conclusion is that it has stuck down a lot of other treatments. It seems to promote, it is definitely promoting exercise as a very, very, very good strategy, the way we can manage our shoulder pain. Then this is something that I wanted to present here, because when we look into adhesive capsulitis, a frozen shoulder, periarthritis shoulder, it's something, our very own first thought is that it is something to do with, there's a stiffness, there are adhesions, and we have to break and we have to mobilize. And once we improve the range of movement, it goes up. But in a lot of patients, especially in a lot of old patients, if you see that how long have you had this, they say that I have it for a very, very long time. Generally, PS shoulders, generally, what happens is they can get better on their own. But why should we address these problems quickly? Because when there's a lot of pain and lack of movement, that means that you're not able to do certain things that you used to do earlier, can actually cause a lot of depression, that you might feel really low. And due to the pain, patients won't be able to lie down on that side. They say, when I turn, I have pain. When I lie down on that side, I have pain. So there's lack of sleep, and the person is already feeling depressed, low, because is not able to do. For example, people who are very used to housework, they can't even pick up something in the kitchen. It's a very, very difficult thing for them, and they can't hang out clothes, or they can't undress themselves, they can't dress themselves, they can't put on shirts. So things like this can actually make people feel really, really low. So if you have a combination of pain and a lack of sleep, and patient is already feeling very low, this is really, really a bad triangle. It's a bad triangle because it can cause a lot of central nervous system changes. It can lead to chronic pain and central sensitization. In that case, then it's going to stay there with the patient for a long, long time, and you don't need to have a structural cause to have a chronic pain, because it's something to do with your neural changes. So it is very, very important that we look into these stages and we resolve PA shoulder as quick as we can using various mobilization techniques, by educating the patient and by enabling the patient. Okay, that's why I put in, because we can't take adhesive capsulitis as just something structural when it can be causing something really potential harm to the patient with chronic pain and central sensitization of the pain, because undoing chronic pain is again a very, very big process. Then diagnosis, like I said, the ground rule is to diagnose. Do we have to always give them a diagnosis? Do we have to always give them a fancy label telling that this is what is causing your problem? This is the structure. You have so many fancy labels in the world of science. So do we always have to give them an exact diagnosis of what really is happening? The ground rule is always explain the problems to the patient. So you explain the problem. So tell them that this is what is happening. So to explain the problems effectively, what you need to do is you need to understand the understanding of the patient. You need to have an understanding of what patient thinks of his problem. So a lot of patients, like for example, when they complain that my arm feels like dead, I don't feel like my arm is connected. So a lot of complaints like this will give you information on their beliefs and attitudes on what they think is happening to them and what is causing their pain. For example, you can understand their negative beliefs. If you understand their negative beliefs, if you know how the patient is thinking, then you can always correct them and tell them that might not be the cause. This might be the cause. So when you are explaining to them, always give them credible terms. Credible terms. As a clinician, you should know what is credible to say. And for example, you can't just tell them that it's impingement, because impingement is something, it doesn't look like it's a good way to explain problems, because it's a common thing. And when you say impingement, it kind of gives a negative feeling that if I do certain things, that means my structures are getting pinched somewhere by a bone above or a bone below. And you should always give them, explain them things which are not harmful. For example, if you say that um, when you do certain movement, this is what is happening, that your muscle is going and getting impinged, then they might as well just stop that whole thing. One such terrible examples that I've come across from one of the clinicians in one of the webinars, and a friend of mine who has shared this experience with me, telling that a lady has to undergo an abortion because her physio said that you have a very weak core. I don't think so you'll be able to handle it as it goes. So you need to strengthen more on your core muscle. So she got really scared that her back won't have the capacity to handle. So she has actually aborted her baby. So things like that. We need to be very careful on what and how we are explaining things to patients. Generally, what I do is I'll tell them that, see, at this moment, this is something that you're not able to do. This could be not temporary. This is something to do with muscle, something to do with muscle weakness. And I've tried to explain them the information of what could be happening there and how they feel pain, and they can always get better with exercising. And treatment, as we have discussed earlier, it's no point using modalities and fancy treatments when they're not adding any value. If the patient has expectations, you can actually, to satisfy patient expectations, you can do a bit of it, but you should always explain the patient of what really is happening with these methods of treatment and how effective are they, if they can really change things for the patient or not, or if they're giving the placebo effect. So there's a good study, I have mentioned it in the slide, effectiveness of physical therapy treatment of clearly defined subacromial pain, a review of RCTs. Please give it a read. There are 64 RCTs that have been reviewed in this study, and it shows how effective exercise is when compared to other methods. And the world is growing, and there's growing research. The paper gives you a good example, and we cannot actually change ourselves or the beliefs of the patients overnight. But you might be thinking that, okay, this person might be practicing overseas, might be really hard. No, but there are clinicians everywhere with different mindsets. I have had clinicians which emphasize on a lot on manual therapy, but also patients who choose manual therapy over active approaches. So passive approaches are still, still in demand. But I would never leave out a chance on educating my patient on what an active approach can do to their life. So it always give an upper hand to high value care, which is very, very important. So as a part of high value care, I would always educate the patient. I would always tell them, see, this might take this long, this might be happening with you. And a lot of patients have expectations, because the first question they would ask, do you think that we can treat this? Do you think how long it will take? Because everybody wants to know how long it's going to take. And always address fears. Like, for example, say bone impinging onto soft tissue. Explain them the mechanism of what might be really happening. And a lot of people have fears over medical imaging. So once they have an X-ray or other scan, they would come up with, the diagnosis and say, this is what is happening. But also, it is a very, very tricky part, and it's very, very difficult to explain things to patients on imaging, because imaging is something which actually is a clear picture of what's happening inside. But research says otherwise, because there are a lot of good studies by the below people, and they're saying that 40% of rotator cuff tears are asymptomatic. And also, there was a study that clinicians conducted where they have taken scans of both the shoulders, and both the shoulders have tears in rotator cuff tendons, but one side is symptomatic and one side is asymptomatic, which came as quite a shock to a lot of patients and clinicians as well. So a lot of things, like very, very poor evidence for manual therapy that we do, despite of, we don't even think of if that is going to do any better to patient, but we just emphasize on, we just get in and we always want to do something manual. I have nothing against manual therapy, but we'd only do when it is needed, and should always educate the patient of what you're doing and why you're doing, because the patient should not really think that, you're actually being some magicians, that you are actually, doing some magic or that. That's how we would feel like, because that's how I once was a person like that, I used to take a lot of credits. When patient comes in, they say that I have this problem. Now I feel all fine. Thanks to I used to take all those credits, but I feel that it is more important rather than taking credits. You need to enable the patient. You need to build that confidence in the patient that, that they can handle this problem on their own. You should not really create that clinical dependency. Patients should not come and see you again and again, that they have to come and see you to get rid of the problems. No, a lot of problems can be dealt with if you create that, if you enable the patients, if you give them that self-confidence that they can deal with the problems on their own, that definitely helps the patient. That is what a true clinician should do. And I would always highlight active exercising. Active exercising is something that I would always look into. And as a part of exercising, what I would always do is I would always develop a tailor-made exercise programs for my patients, because it could be as simple as that. A patient can tell me that. I would always ask them, very simple. For me, the treatment is very simple, because I'd always, my treatment is problem-based. So I always ask them, what do you face now? I totally understand you have this problem. So what is the difficulty that what is that you're not able to do that you used to do before this problem? A lot of patients might say, I'm not able to play with my grandchild. Few people who are managing homes might say, I'm not able to do this. I'm not able to iron, or I'm not able to put dry my clothes, I'm not able to cook effectively. And few people might say, I'm not able to lie down. So what I would do is I'd focus on addressing these problems. Those would be my outcome measures. Alongside pain vascular or NPRS, but I would have mainly my outcome measures are, what are the problems that patient has mentioned to you? How can you help the patient to get better? So I would always look into painful exercises and non-painful exercises. I had a very, 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 very bad past when I always used to tell patients that you can always stop the exercises if you think that is hurting you. But research says otherwise. Chris Littlewood is one of the legends in research and shoulders, who says that his study says that even the painful exercises have given a similar result when compared to non-painful exercises. But you always have to educate the patient. So on how I would educate the patient is, I'd always tell them, these exercises might cause you pain. You can always stop the exercises if you think that these exercises are giving you a lot of discomfort that you cannot really manage on your own. If you notice that the pain is only aggravating, and if it is not coming down after the exercise, and if you have pain for a certain period of time, if pain is excruciating, you can always stop the exercises. But if you have pain that subsides as soon as you stop your exercising, or subsides within a period of time after you finish exercising, then please continue with those exercises. Then I would always try to challenge my patients. I see patients as two categories. I see them, the interest that they have in exercising. And there are patients with whom I would always start them off with very, very simple exercises. It could be as simple as, can you just do scapular retraction? Can you just bring your shoulder blades together, hold it there for a count of 10, then just slowly let it go? And it could be as simple as, can you just lift your hands up to a 90 degrees level? Can you hold them there for 10 counts? My very aim is to get the patient moving, or get the patient to do some kind of exercise rather than not do anything, rather than be completely dependent on you, for you to interfere and do something hands-on. So that is one set of patients where I would just want them to start doing something, because when they feel confident that they can do something, when they achieve certain things. For example, I give a very simple goal. Always look on giving a patient a short, simple, achievable goal, SAS. So what I do is, I would always ask the patient, for example, I just give them, can you do this a set of 10 reps every day for next 1 week? So the next time I see the patient is much confident because he knows that he can do. If you give them 10 exercises with 10 reps, 3 sets, 10 counts hold, the possibility is that the patient would never do one of them. He might be just doing 3 reps of 2 exercises. So you should always need to create. Your job is, so I did this blunder as well back home when I used to practice. I tell them that, see, it is totally up to you. If you don't do the exercises, then you're losing a lot. So I used to put this blame on patients for not doing the exercises, but I never looked into why are they not doing exercises. Because as a therapist, you are responsible for your patient. You need to get them to exercising. So how do you do that? You always give them simple exercises, easily done, easy number of repetitions, and always ask the patient. So if you want, you can always do it in your own time. A lot of patients say they don't have time. So you create that exercise adherence. in patients. So second category of patients who are really active and who are really wanting to do a lot of exercising. For example, let's just say the patient is having pain here, and what I do is in such very active patients who want to do a lot of exercise, I always test their limits. So what I do is, can you just start off your exercise? So I always say, can tell me when you're having pain. They say that this is where I'm starting to have pain. Then say, let's just say we do some weights right here. Just go back and just do some weights there. So I would always take them to their limit and push a bit towards a new barrier, but not like so much. Not, you don't set a new barrier from here to here, but you always set a new barrier from here to here. Your barrier, you need to set an easily achievable barrier so that the patient will have self-confidence that he can do it on his own. And instead of doing a lot of tests, there are a lot of tests that you can do, but those tests are not adding any value to the patient, and they're not, they're consuming a lot of time. What I would do is, I would rather test the patient. What I would do is, what I started doing is, I have learned this from a mentor. My mentor would actually demonstrate a quick few exercises. Let's just say you try a bit of isometric exercises in your clinic. Next time when you have a shoulder patient, a patient with who has pain, what you can do is, like we have muscle energy techniques, and we have also exercising. What we can do is we can give them a quick demo. What I would do is I always ask them to do a quick resisted isometrics. Let it be against a door or a wall, or let it be against your hand. I'd always ask them to do an ER and an IR, and then I'd always ask the patients to do all exercises, just 3 reps, 10 counts hold. That should not take less than 2 minutes. Then I would tell them, now if you want to lift your hand, lift it up. A lot of patients would definitely feel a bit better in lifting hand. It might not change anything in pain, but it would definitely affect the way they move. So that itself will give them a confidence that, yes, exercise seems to work. A lot of patients are first not confident in exercise helping them, but once they start learning, once they start doing it, they would feel a difference, and they would tell, that exercise is really helping me. If it is not helping, it's not necessary, it's not mandatory that exercise should help everybody. If it's not helping, then you would do assessment and then look into how you can progress with the patient. And there are a lot of other chronic pain conditions. You need to deal with them differently. A lot of education has to be put in, and a lot of fears and beliefs are to be addressed. And you should always treat them actively rather than passive approaches. And for rotator cuff pathology, from Dr. Chris Littlewood's studies, it says that a 12-week exercise program seems to be really effective. And also Dr. Linwood discussed about 3 sets of exercise seem to have a good effect more than 2 sets of 1 set. But at the same time, we don't know how many reps are ineffective in each set. So finally, I want to thank my mentor, Jonathan Scattergood, and also Dr. Chris Littlewood, who has inspired me with a lot of his studies, which helped me read more on shoulder, and Dr. Deepak Sebastian, my teacher, who's inspired me to study musculoskeletal physiotherapy. And wherever I wherever I do a webinar, I have something called a Pearls of Wisdom, which I took from my very great teacher, Dr. Deepak. They always told me that head, heart, and hands should work together for you to be a great clinician. Your head, you should always use all the knowledge that you have, and your heart, you should not just empathize using your head, but also you should sympathize with the patient with your heart, and you should do the right treatment with your hands. You should do the right assessment with your hands to avoid promoting negative beliefs and attitudes. That what will make you a true clinician. And thank you all for patient hearing. And you can ask me questions if you have any. I can answer them. Thank you.
Good evening, Nidheesh, and thank you for this wonderful talk. What we take from your lecture is a lot of tick boxes you have checked on, and a lot of myths have been answered. I don't know whether to call it myth or the way of curriculum that we follow. But I still would have a question that whenever you come across a patient of shoulder pain, is it right to consider it a non-structural pain?
No, sir, we should not do that. We should definitely examine the patient based on the complaints given by the patient. It definitely, pain is definitely structural, but not all times.
Okay, So we assume that the pain is structural, but we are not able to identify the exact structure through physical tests.
Yes, sir. A lot of physical tests are not specific, like I said, but because the world is growing and I am actually I have a lot of interest in reading chronic pain. When I say pain is structural, um, it is not always, because a lot of times chronic pain is generally not structural, because if we look at the healing periods of various structures, generally we should get over with it the max of 6 months maybe. But if there is pain, if there's only pain even after we have the problem, but still the pain is really persistent, then it is definitely non-structural. So if you're looking at acute cases, acute causes, then considering taking the history into consideration, then we can actually decide if it is structural or non-structural. But what we have, the test that we have in hand, might not differentiate and determine that this might be causing this problem. But I would always say that there are a few tests that I've presented you with, like ruling out instabilities and cluster tests to rule out certain problems.
Yes.
They really are specific in nature. I would definitely believe in those structures, tests to identify structures.
Right. And Nidheesh, which of the two patients, if you have a patient with acute pain and a patient with chronic pain, which of the two would you like to be more self-dependent for his own care?
I would want both the patients to be self-dependent on their own care, but I would, being somebody who is interested in chronic pain, I would emphasize my chronic pain patient to be more self-reliable. Like I'll ask them to do, I'll push them through more passive, some more active treatments than passive methods. But I would always promote active approaches with my patients. Only
Active
when needed,
approaches.
I will do passive approaches.
Right. So if you have to place them in hierarchy of physical agents or electrophysical agents, manipulation, advice and education, or active exercises, how would you place them in hierarchy of needs?
Sir, it's been firstly, it's been a long time that I've used electrical modalities, because
So I understand that, yes.
in India, no, sir, it's not just because of UK. In India, the place where I practiced, I worked with an orthopedic surgeon who specialized in sports medicine, who is quite popular, in fact.
Right.
And he absolutely had no belief in whatsoever in medical, electrical modalities. So he always wanted me to promote active approaches. And but we had ultrasound back then. Apart from that, we really didn't had anything else to practice. So I have developed this attitude of dealing with active exercising. But if you say that if you want to put it in a hierarchical order, in a hierarchy, I would always look into educating and advising my patients, followed by, or parallelly, we can't actually do it as self alone or standalone methods. So I would do each other to complement each other. So I would educate, advise, and active exercising would be my first option. And based on patients' expectations and movement restrictions, I would look into the usage of manual therapy, but electrical modalities would definitely be at the baseline for me.
Right. And Nidheesh, I end with the last question of how much would you blame posture for shoulder pains?
So posture is again a very tricky thing. I've read a quote somewhere saying that the far you stand away from the plumb line is, that good is your posture, or that normal is your posture, because we have plumb lines. We actually identify, because posture is something that we have so much of myth going around posture, because we say that this is normal, this is abnormal, because for example,
That
sir,
is
I
so
have
individual. Yes,
sir, very individual. I have something called as, I have identified myself. Definitely, I have rounded shoulders, but touch wood, I didn't had any shoulder pain yet. I used to be very active. I'm very active. I used to play a lot of basketball and badminton. So it is something very individualized. So I don't believe in normal and abnormal postures, but we look at change postures every day. Posture for me is something that is acquired. It could be because of aging, but I don't know. I'm yet to jump to a conclusion of this could be normal and this could be abnormal, because we are looking at structures there.
Right. Thank you so much, Nidheesh, for being with us and sharing this wonderful knowledge. And I think upcoming and budding therapists must have a look at this video and plan and prepare their treatment and question what is in the textbooks. Thank you so much for being with us.
Thank you, sir.